All right. Thank you, everyone who's staying for the breast session. Our first speaker for breast imaging is Dr. Ashley Huppe. She is an associate professor of radiology at the University of Kansas Health System. She's also our breast imaging fellowship program director. And I'll give the microphone to Dr. Huppe.
Okay. Thank you so much. Let's see if okay, perfect. So we're going to do a kind of a 3-point or 3-part lecture series that all kind of blends together. I'm going to start by talking about updates in screening, talk about different patient populations and how we screen them. Dr. Winblad's going to talk about density and some FDA updates, supplemental screening, and then we'll finish off with some case review. So I have no disclosures. Objectives for this first talk are to understand the use of risk assessment, review our updated breast cancer screening guidelines by risk status, and then learn the screening guidelines for special populations. So why do we screen? We all know breast cancer is common. It's the second most common cause of cancer death in females, but it's curable when it's detected early. So screening mammography has been repeatedly proven with randomized controlled trials to decrease mortality by 30 to 40%, but there is some reduced sensitivity in our higher risk populations. So when we talk about average risk, it's that 1 in 8 lifetime risk, about 12.5%. And we follow the ACR and SBI guidelines for annual screening starting at age 40. And there's no age limit to that. So that is an individual discussion with your provider. So this is regulated by the FDA. I believe Dr. Winblad is going to talk a little bit more about that. But just know now that the majority of screening mammography is digital breast tomosynthesis. 92% of accredited facilities now offer that as of the statistics earlier this year. So what do we talk about when we say higher than average risk? So what does that mean? Basically, any patient that has risk factors other than just being a woman. This does include just having dense tissue. And how is this assessed? This is assessed in a couple ways, informally at primary care offices or when patients come in for their breast imaging, just on our routine intake forms. And then it's also assessed formally by high risk providers, breast cancer prevention clinics, but that also relies on the patient being correctly referred there in the first place. And so this can include questionnaires on the patient risk, family history, and then input into various risk models. And ideally, we're doing this by age 25 to 30. So there's really no single method or definition used to classify risk, but typically it's put into 3 categories: average, intermediate, and high. And then these days you'll see a lot of people using the term elevated or higher than average risk, and that's kind of lumping that intermediate and high risk status together. And there's several different risk models that we can use, but the most commonly used is the Tyrer-Cuzick. So for high-risk patients, that's considered a greater than 20% lifetime risk of developing breast cancer. These risk categories are very well agreed upon. These are patients with genetic mutations or their first-degree untested relatives, patients that have had chest or abdominal radiation therapy, and a calculated risk of greater than 20% based off family history. And for those patients, we recommend annual MRI. The starting age varies by risk factor, but we don't recommend any screening before age 25. And this is because MRI is validated to reduce both interval cancers and improve the incidence of late stage disease. So just a quick aside on screening MRI, I think Dr. Winblad might go further into this, but we do have 2 different options: the traditional full protocol, which is a longer exam scheduled in typically a 45-minute time slot that includes multiple post-contrast series. Now we offer something called abbreviated MRI. This is becoming increasingly popular. There's no established protocol at this time, but typically patient facilities are reducing the number of post-contrast and extra sequences. And so these can be as short as 5 minutes or even less, and they're scheduled in shorter time slots so that that increases patient throughput and satisfaction. Both of these exams do require IV gadolinium. And just as far as the ACR appropriateness criteria says, I thought this was interesting to show that they do lump both abbreviated and full protocol MRI into the same recommendation categories. So they're not differentiating between those 2 exams. So intermediate risk are patients in that 15 to 20% lifetime risk. This includes patients with a personal history of breast cancer, particularly those diagnosed before the age of 50 or with dense breast tissue. Patients with a personal history of atypia, that includes ADH, ALH, and LCIS. And then patients with just dense breast tissue as their only risk factor. So all three of these categories are now recommended to undergo annual MRI. This is per the recent updated guidelines in 2023 from the ACR. We are seeing an increasing risk of cancer in younger generations. This is just a couple headlines that showed up recently. 17 of 34 cancer types, this includes breast, are increasing in the Gen X and millennial generations. And I think the reason that this is important is these are the generations that are increasingly reaching screening age. And so we need to be armed and prepared with the tools to be able to screen them appropriately and identify them at the appropriate time. So moving into our special populations, where we're going to review guidelines for male patients, transgender, pregnant and lactating, and post-surgical. So for men, these account for about 1% of breast cancers. So, this is a small percentage of cases. These, unfortunately, are usually diagnosed due to symptoms. So the prognosis is worse with about 20% mortality. The American Society of Clinical Oncology first published guidelines just pretty recently in 2020. So this includes men with a genetic mutation should receive a baseline mammogram. Those with a personal history should receive ipsilateral mammography. And men with a personal history and a genetic mutation should undergo annual mammography. And then after that, the NCCN came out and said that men with a BRCA1 or 2 mutation should undergo annual mammography. The ACR appropriateness criteria now agrees with that, saying that digital breast tomosynthesis screening is usually appropriate in men that are higher than average risk. So this was a nice article that came out a few years ago. They looked at thousands of exams in men, 271 of which were screening, and just really great numbers, way better than we do in female screening. So 18 per thousand cancer detection rate, that's about 3 times what we see for the female population. And most of the screening detected cancers were smaller and node negative. And so, because of review of the current guidelines and the study, we do recommend and perform annual mammography in men who are mutation carriers or have a personal history of breast cancer at our institution. So for transgender patients, moving on to this second special population, we typically look at 4 different things to help us decide whether or not we're going to screen them and what type of a screening is appropriate. 1 is going to be their sex assigned at birth. 2 are their individual risk factors. 3, the use of hormones. And 4, their surgical history. So for transgender women, we're looking typically at whether or not they're on hormone treatment. And if so, and if it's been greater than 5 years, we do recommend annual screening. For transgender men, again, this is going to depend on if they've had surgery. So typically, if they've had mastectomies, they do not need screening. I have a little caveat there is that top surgery is not always equivalent to a full mastectomy. So if there is concern for residual tissue, it may be appropriate to continue screening these patients. And then patients that have not had any surgery should undergo screening recommendations as recommended for cisgender women. And then this was just a nice flow chart here from the Mayo Clinic proceedings, kind of highlighting and detailing all of the recommendations I just discussed. So for pregnant and lactating patients, breast cancer is the most common invasive malignancy diagnosed during pregnancy. And a pregnancy-associated breast cancer is any cancer diagnosed during pregnancy or within 1 year of having the baby. So these are increasingly becoming more common because women are delaying childbearing. So it's important that we discuss how we screen these patients. So I think the most important thing is that we perform screening mammography in pregnant and lactating patients, regardless of the fact of they're pregnant or lactating. So it's the estimated dose to the fetus is incredibly low and far outweighs, or the benefit of mammography far outweighs the risk to the fetus. For higher than average risk patients that would typically be recommended for some sort of supplemental screening, really the only change is that we don't perform MRI in pregnant patients. We do perform it in lactating patients. I see this almost every week, but gadolinium is contraindicated during pregnancy. So typically our patients will undergo ultrasound screening during that time period if they're high enough risk. And then lastly, post-surgical patients. This includes patients that have had breast conservation therapy or lumpectomies, and they can resume normal mammographic screening as soon as they're finished with their definitive surgical therapy. Some institutions will do a diagnostic mammogram maybe the first time back, but typically we want to get these patients back into a screening pool pretty soon. And then patients with mastectomy, we do not recommend any routine screening unless it was a unilateral mastectomy. Then we will resume screening for the contralateral breast. Occasionally, we do perform mammography in patients that have had a flap reconstruction or implant reconstruction for diagnostic purposes, but not for screening. So how do we approach this at KU? I recommend, if you have high-risk providers that you're referring to or have a relationship with, talk to them so you guys can get on the same page. Try to identify the individual patients throughout the day as you're reading. And developing a macro to use for these patients can be really helpful so you don't have to think about it every time. You just see the patient's high risk, you throw it in your report, and then they have the information. And then if the opportunity presents itself, I try to discuss this with patients. So say I have a 28-year-old that comes in for a palp, but the exam's negative, but we identify that she's high risk. That's a great opportunity to go in and talk to them and hopefully get them in the appropriate screening category. This is a nice flow chart from densebreasttissue.org if, to kind of help out with these patterns in screening and how to identify these patients. So in summary, for average risk patients, we perform annual mammograms starting at age 40. For elevated risk, for most patients, we are now recommending annual MRI. So that's patients that are high risk due to the traditional criteria, as well as patients with a personal history, patients with dense breast tissue alone, and a personal history of atypia. For men, we are screening men that are in the higher risk category or higher than average risk. For transgender patients, the guidelines are based on their sex assigned at birth, their medical and surgical history, and their personal risk. Pregnant and lactating patients screen as you normally would with mammography, and then the exception is no MRI in pregnant patients. And for post-surgical patients, if they've had mastectomy, no screening, but otherwise, these patients can return straight to routine screening. All right, so that one was a little bit quick, so hopefully we can use a little bit more time later on with case examples. So Dr. Winblad is next. She needs no introduction, but she is our division director and also an associate professor of radiology at the University of Kansas, and she's going to talk to us about breast density.
Thank you, Dr. Huppe. That was such a fantastic lecture. And I know everyone in the room, especially Dr. NCRD, Dr. Gibbs, know how much screening guidelines have changed in the last 15 to 20 years, especially for special populations. So such a relevant lecture. And that leads nicely into the next topic, which is breast density. Also kind of a hot topic in the past 10 years with lots of updates. I have no disclosures to report. These are the learning objectives of this lecture. Most importantly, I mean, everyone in here does some breast, so you already know this, but I've done my job if everyone here feels like they left this lecture and can have an effective conversation with the patient, with your colleagues, with referring providers, and that you know what to do for patients that have dense breast tissue, especially locally and in your institution. So we'll talk about the impact of breast density. We'll review the new FDA regulations. We'll talk about the different supplemental screening options, especially those that are now endorsed by the ACR recommendations. And we'll talk a little bit about insurance coverage and how that may affect what you recommend for your patients or offer locally. So what is breast density? So it is the amount of fibroglandular density tissue comparative to fatty tissue in the breast on mammogram. It's defined or assigned on a mammogram, not physical breast exam. You can assign this subjectively as the interpreting radiologist. At our institution, we use a software that provides a little bit more of an objective assessment and less inter-reader variability, though we can override that assessment. And it's important to know that breast density changes with time and to let your referring providers know that it's not uncommon for a patient's breast density to change, especially as they age, just a normal age-related change in breast density if they've started hormone replacement therapy or have significant weight fluctuations. There are 4 categories of breast density assigned by the ACR criteria. The two non-dense categories are categories A and B, almost entirely fatty and scattered areas of fibroglandular density. And these are the two categories we're interested in today. Categories C and D, these are the dense categories, heterogeneously dense and extremely dense. This slide nicely illustrates the mammographic appearance of the four different breast density categories. As you can see, breast density is divided into quartiles based on the amount of fibroglandular tissue within a patient's breast. The two dense categories are on the right-hand side of the screen, the heterogeneously dense and extremely dense breast, and these have greater than 50% fibroglandular tissue. About 40 to 50% of women undergoing screening mammography have dense breast tissue. So this is common, it's normal, but it's important for two reasons. Number one, having dense breast tissue is an independent risk factor for breast cancer. So for women who have dense breast tissue and no other breast cancer risk factors, they're already at the intermediate risk category with a lifetime risk of breast cancer 15 to 19%. And number two, breast cancer is more challenging for the radiologist to find on mammography when patients have dense breast tissue. So breast cancer is white, fibroglandular tissue is white, so breast cancers are just more challenging for us to find. This is termed the masking effect. And we know that we're missing up to 50% of breast cancers and patients with extremely dense tissue. I love this slide. We're going to talk about all of these patients as we go through this lecture, but these are four different patients. They all have breast cancer. If you look on the left, the patient has fatty breast tissue, and the small cancer is incredibly easy to see. We wouldn't miss that. But if you look at our next three patients, they all have dense breast tissue. Those patients all have cancer, and they all had normal mammograms. So we're going to talk about this and really talk about how the masking effect comes into play. So because patients with dense tissue are more likely to have cancer and it's more difficult to find, these patients have a higher rate of interval and advanced breast cancers. And we know that interval and advanced breast cancer are surrogate measures of mortality. So we know that these patients are at a disadvantage. So interval cancers, those are the cancers that present between screening intervals, which means we either miss them or they're high grade and fast growing. And then, of course, advanced breast cancers are cancers that are larger. They've spread to lymph nodes or maybe metastasized. And ultimately, as we know, the goal of screening is to find breast cancer when it's small and treatable. When we find breast cancer at a local stage, the 5-year survival rate is 99%. We're just not doing that for our patients with dense breast tissue, those patients that are presenting with more advanced cancers. Because of the implications of breast density and the impact it has on patient outcomes, medical organizations, advocacy groups, politicians, celebrities, you name it, began bringing awareness to breast density several years ago, bringing awareness and demanding patient notification of breast density, asking for supplemental screening for patients, asking for insurance coverage of supplemental exams. And then in 2019, Congress passed a bill mandating that the FDA establishes a breast density notification nationally. The final rule was issued by the FDA 4 years later in 2023, so pretty recently. This final rule amended regulations of the MQSA. And then in September 2024, the FDA began enforcing regulations for breast density reporting. It's really important to note that all facilities that perform mammograms must comply with the MQSA final rule. So if you're interpreting breast imaging or mammograms in your practice, it's really important you understand what this new rule is requiring. So one of the requirements, and one of the most important requirements, is that we notify patients of their breast density. And we must tell patients their density using the exact verbiage from those ACR classifications of breast density, the A, B, C, D that we talked about earlier. Now, if you notice looking at this chart, and those are written in plural form, so you can see if patients have a bilateral or a unilateral mammogram, that terminology can be kind of confusing. You may have seen recently an update to the MQSA regulations. There's an alternate standard that's now available for use, and it's approved. And it allows for singular verbiage or kind of a neutral verbiage. So I'll show you what that looks like. So the singular verbiage is intended to be used for unilateral mammograms, and it's written in the singular phrasing. There's also neutral verbiage, which essentially says breast density and then gives, neither singular nor plural phrasing. At our institution, we elected to adopt the neutral phrasing to keep this simple across all mammograms, and this was easiest for our EMR to do it this way. So not only do we need to tell patients their breast density, but we also need to give them the dense or not dense verbiage in their patient lay summary. So if your patient is dense, their letter must tell them that, this statement, breast tissue can be either dense or not dense. Dense tissue makes it harder to find breast cancer on mammogram and raises the risk of developing breast cancer. Your breast tissue is dense, and some people with dense tissue, additional imaging tests are needed. Talk to your healthcare provider. So your patients are getting this information now. They're going to ask questions. They want to know what to do next. Just as a reminder, this language cannot be altered. You have to use this language verbatim. You can't change it at your institution to, be more reasonable for your patient population or your electronic medical record system. You have to use this language verbatim. And it applies to all mammograms. So sometimes it seems silly, right? You have to use this for post-procedure mammograms and male patients, as Dr. Huppe was talking about. All patients that have a mammogram all of the MQSA final rule will apply to all mammograms. So let's switch gears and talk about what to do for patients. When they find out they have dense breast tissue, what can we do for them? We do have really fantastic supplemental screening options. Lots of new studies in the last 10 years showing really good evidence that these are great tools. So we're going to talk today about the most widely utilized and endorsed options, which are breast MRI, contrast enhanced mammography, and breast ultrasound, either with automated or handheld probes. All of these, as you know, have different limitations and advantages. And probably most importantly, the availability of these different studies just widely varies across the country, across the state, in your community, even within your institution at different facilities. So you have to kind of know what's available for your patients to know what to recommend. But also important, don't forget that patients with dense breast tissue still need to have their annual screening mammogram. Supplemental screening options do not replace the annual screening mammogram. Dr. Huppe just mentioned this, but thankfully we have more evidence-based guidelines for breast cancer screening. The ACR published their updated breast cancer screening guidelines in 2023 for higher than average risk patients, and this included the recommendation for patients with dense breast tissue. And so this really helped all of us, back our recommendations and our guidelines that we're giving to our providers and our patients. And the ACR recommends annual MRI with CEM and breast ultrasound as alternatives. So breast MRI, this is the leading recommendation. We all know it has the highest sensitivity for breast cancer detection. Probably more importantly, study after study shows low to no interval cancers. And that really is the most important. Those are the cancers that, have a higher mortality, that are more lethal than other cancers. But breast MRI is not perfect. That's why we need to offer more than one type of study to cover the large patient population that has dense breast tissue. It requires an IV, gadolinium contrast. A lot of patients have claustrophobia or, weight or size constraints and then cannot get in the MRI scanner. Across the country, pretty poor access. So lots of reasons that breast MRI is challenging for our patients. Cost and access have definitely improved with abbreviated protocols. So that has significantly helped us. This was the slide that illustrated the masking effect of dense breast tissue. Our patient on the right elected to have a breast MRI screening. This is this patient's mammogram, extremely dense, normal mammogram. We don't see anything. This is the patient's breast MRI. This is a subtracted MIP image from the patient's screening breast MRI. This is a pretty large enhancing mass in the central breast. I would venture to say this is probably the largest screen detected mass we've had on a breast MRI. Most of them are much smaller, but it really goes to show you what can be hiding in dense breast tissue. Contrast enhanced mammography. This is kind of the new kid in town. It's gaining popularity across the country. We do offer this at our institution, and it's showing in study after study that the sensitivity for breast cancer detection is approaching MRI. So we're seeing that it's probably about 10 additional cancers per thousand, not quite as high as MRI, but maybe even better specificity than MRI. That's great. Patients tend to love it. Exam time is really short. It's 10 minutes, so similar to abbreviated breast MRI, really short exam time. Patients prefer it over a breast MRI, and studies show that as well. Definitely lower implementation costs. Most facilities have mammo units that can just have simple software upgrades to be able to perform CEM. There are some disadvantages, so requires an IV and iodine contrast. And most of the disadvantages for CEM are related to, patients who cannot have iodine contrast. So our patient number 3 had a CEM. This is actually a patient who was high risk and was not able to undergo breast MRI for a contraindication. This is a really beautiful case. And if you haven't seen any CEM studies, the top images are the low energy image that's similar to the 2D image. The bottom images are the recombined image. So it's similar to subtracted image from a breast MRI. This shows the breast cancer enhancing in the right breast very nicely. That 12 o'clock enhancing mass in the right breast proved to be an invasive ductal carcinoma in a high-risk patient. Breast ultrasound is still the most widely utilized breast cancer screening tool, and it makes sense. It's well tolerated. It doesn't require an IV or contrast. Unfortunately, it is operator dependent. So the performance profile of breast ultrasound will vary across, locally across the country. The lowest cancer detection rate of all the screening modalities. However, the cancers that we find by ultrasound are small, node negative. Those are the cancers we want to find. Those are the cancers that allow us to, increase survival for patients and decrease morbidity. So it still does a good job, but not quite as good as CEM or MRI. Our second patient underwent breast ultrasound screening with an automated ultrasound, which is the larger probe. You can see this patient has heterogeneously dense breast. The mammogram is normal. We don't see any abnormalities. On the automated breast ultrasound image, which you can see on the right-hand side of the screen, this patient has a small irregular hypoechoic mass. This is the classic, invasive ductal cancer that we see on screening ultrasound. And then I just threw in another patient that had a handheld ultrasound screening detected cancer. When we're doing handheld ultrasounds, remember these are more operator dependent. You really need skilled breast sonographers or physicians performing these studies to ensure that you're making the findings. So these do require a little bit more training for your sonographers. So we've come a long way with breast density. Even since I began practice 11 years ago, we're finally telling patients what their breast density is. And there's federal legislation requiring that. We have great supplemental screening tests and finally some good evidence-based guidelines so we know what to tell our patients and providers. Unfortunately, this doesn't mean that these exams are always going to be covered for our patients or available. So we know the Affordable Care Act mandates that insurance payers cover screening mammogram at with no cost sharing. That does not apply to supplemental screening. Several states do have laws in place requiring coverage for supplemental exams for patients who are high risk or have dense breast tissue. But very often these exams are still subject to cost sharing, copays and deductibles. And we all know a lot of patients these days have high deductible plans. To make matters more challenging for our patients and providers, abbreviated MRI and CEM, two of our leading recommendations for supplemental screening in this patient population, don't have dedicated CPT codes. So what this means is that the billing, varies by institution. So that can be challenging depending on how your institution bills for these studies. There's some hope on the horizon for insurance coverage. The Find It Early Act, originally introduced in 2022, did not gain a lot of traction. This was a federal law that, if enacted, would not only require insurance payers to cover screening mammography, but also supplemental exams for patients with dense breast tissue or high risk. This legislation was reintroduced in 2023 and 2024. It now is a little bit more bipartisan support and hopefully will be reintroduced in 2025. I think when it comes to dense breast tissue, I talk a lot about this. I get so many questions about dense breast tissue and what to do and what's available. I think what's most important is having a decision tree available for your patients and providers at your institution. Because the local availability of these studies varies and the insurance coverage varies, you need to give them some sort of guideline about what to do next. So, at our institution, we offer breast MRI, contrast enhanced mammography, ultrasound, both automated probe and handheld probe. So we've made a nice decision tree to hopefully help our providers and patients decide what works best for them. And you start at the top with breast MRI being the leading recommendation, but we know all patients can't have MRI. And whether they have a contraindication or whether they simply need to elect an option that their insurance, payer will cover, that's up to them. But providing guidance is really helpful for these patients. So in summary, breast density is assigned on a mammogram. Federal law now requires that we notify patients of their breast density on mammogram. Don't forget, it's common, it's normal, it's nothing that patients should freak out about when they see it on their mammogram report. But patients do have, higher risk, and we miss more cancers in this patient population. We know that mammograms aren't perfect in these patients. So in addition to the annual screening mammogram, patients with dense breast tissue can opt for one additional screening test. Breast MRI is the leading recommendation according to guidelines, with CEM and ultrasound as really great alternatives. And then remembering to remind patients that MRI and CEM do require an IV and contrast that may affect the type of exam that they elect for. And then I think this is important. Know what's available locally within your institution. Know what insurance payers are covering within your, local environment. This will really allow you to hopefully develop personalized screening approaches within your institutions and for your patients. And don't forget, if patients have questions for you about coverage, they can very often just contact their insurance provider to see what their individual plan allows for them. That's it. Thank you, everyone, for staying for this breast talk. And then we will move just to stay on time so that everyone can get lunch and be ready for the lecture at 12:30. We'll move on to Dr. Huppe, who will now go through a case-based review and really talk about all these concepts and show you really great cases of finding those screen-detected cancers in practice.
Okay. So we'll round out this discussion with some personalized screening in practice. Hopefully, this will be kind of a more fun way to talk about all of these topics. So we're going to practice personalized screening and cancer detection through case review, and then review and consolidate our screening recommendations for all the populations presented earlier in our lecture series. So our first case is a 55-year-old who presents for screening. She has no risk factors for breast cancer other than being female. And here's her mammogram. It's performed and it's read out as normal. So what other additional factor directs this patient's personalized screening? So in this case, the only other thing we need to look at is her density. So any additional testing recommended for this patient? And the answer is no, she's not dense. Recommendation is return to annual screening in 1 year. Our second case is a 40-year-old. She's coming in for her baseline examination. She also has no current complaints. She has no family history or known genetic mutations, but her clinical exam from her primary care provider says she has lumpy, bumpy tissue, fibrocystic disease. So what are you going to do about that? So just taking it back to what Dr. Winblad just talked about, how is dense tissue diagnosed? Well, this is a mammographic finding. And so a lot of practitioners don't always know this or remember this, but it's not a clinical diagnosis. And then, as Dr. Winblad said, our reports as of September of last year are now including this in every mammography report. So what are we going to do next? Well, it depends on her mammogram again. If she's not dense, she can return to screening. If she is dense, the recommended test is an MRI, but she has the option for CEM or ultrasound. And this is her mammogram. So reviewing back to our density quartiles, she does fit in that C or D category, so the dense categories. And she heard that Blue Cross Blue Shield of Kansas is now covering screening breast MRI, which is true. for the moment at least. So she decided, what the heck, I'll get a breast MRI. I've got dense breast tissue. So just a quick aside here, wanted to talk a little bit about some of the techniques we use at KU. We do a lot of abbreviated MRI. It's increasing every single year. And with abbreviated MRI, we just have our single post-contrast series. So you can see on this examination, she has what we would call marked background parenchymal enhancement. That's all that enhancement of her normal tissue bilaterally. And so I know a lot of people that have been reading MRI for many years are used to that kinetic data. So what do we do when we don't have that? We have something called accelerated or ultra-fast MRI, and I'll just dive into that really quickly here. This is basically a high temporal resolution technique, which utilizes that early post-contrast phase. So between when the contrast is injected and that first scan. So it doesn't add any time to the examination, but it helps us capture what we call wash-in kinetic information. And it is performed using kind of an undersampling of the case-based periphery. And what it allows us to do is help improve our specificity and our positive predictive values. We reduce unnecessary follow-ups, but still maintain sensitivity. So what does that look like in practice? So again, here's the MIP from the abbreviated examination, which has marked background parenchymal enhancement. But when we look at our accelerated technique, you see this mass here on the right side of the breast, kind of posteriorly, is enhancing very early. So this first abbreviated or accelerated MIP is 3.5 seconds following the aorta. And then a few seconds later, at about 10.5 seconds after the aorta enhances, you start to see some of that bilateral background parenchymal enhancement come into play there. But the cancer that's in the posterior right breast is enhancing extremely significantly. And this was a triple negative grade 3 invasive ductal carcinoma on biopsy. So our next case is a 78-year-old. She also has dense tissue on her mammogram. You can see there her mammogram was normal. She really wants to do supplemental screening, but she's 78 and says, I really don't want an IV. So what can we do for her? So a couple things about this patient. So one, just, in any patient with dense breast tissue, what are we going to recommend? MRI. We really commonly screen a lot of patients, surprisingly, over the age of 75 with MRI. I think I see an 80-year-old on our list at least once a week. But in this patient, she doesn't want an IV. So CEM would probably be the next best option, but that still requires an IV. So in this patient, handheld or automated breast ultrasound would be our best recommendation. And just a note from the recent guidelines, again, about screening women over the age of 70 or 75, is that there's no age limit at which we stop mammography or supplemental screening. As long as they remain in good overall health and are willing to undergo the examination and any subsequent testing, they should continue with their screening. So this patient elected to undergo automated breast ultrasound, and just a little look at what that looks like if you're not familiar with it. We scan, these are coronal slices, 2 mm slices from front to back, and we start to see a small spiculated mass show up in the left breast there. On automated breast ultrasound, we have 3 orthogonal planes. So there's our coronal view. We see our little mass. It's verified in the sagittal plane as well as the axial plane there. We also get multiple volumes. So in a standard examination, we have an AP, a lateral, and a medial projection. And so we like to confirm the abnormality in 2 volumes. And so here we see it in both the AP and the lateral projection. At KU, we do read these like a true screening exam, like mammography. So we call them back if we find an abnormality for a traditional handheld screening or handheld diagnostic examination. And this again confirms an irregular suspicious mass. The axilla was normal, and this was a grade 2 invasive ductal carcinoma. Our next case is a 35-year-old. She comes in early for her baseline because her primary care noticed that she has a family history of breast cancer in her mother at age 45. Her clinical exam was negative, but the PCP sends her for a screening mammogram and ultrasound. So is this appropriate? Should we perform it? So again, ideally, we're assessing risk in patients by age 25, but as early as we can do it, that's great. Is this patient high risk? So yes, this patient is considered high risk due to her family history. So the appropriate screening regimen for her would be mammogram and MRI. Sometimes, a lot of times, these patients come to us already scheduled. What I tend to do is go ahead and do what was asked for by the primary care provider, but then go talk to the patient afterwards, make sure she has the materials, the numbers to call for her our high risk clinic, and recommend that MRI would be the best test going forward. Next case is a 54-year-old presenting for screening, again, a normal screening mammogram, but she has a newly diagnosed CHEK2 genetic mutation. So she had a family member who was diagnosed with this. She got her testing. So, what do we do for her? So, let's go back to our high risk screening criteria. This is from the first lecture. She does fall into that greater than 20% lifetime risk due to her genetic mutation. So, we recommend MRI screening. This is a beautiful case. This was actually our first screening detected cancer on abbreviated breast MRI back in 2018 when we started this. Another beautiful example of how ultrafast can help us. So this is the abbreviated MIP. You can see an abnormality there in the posterior lateral left breast. When we look at our ultrafast or accelerated technique, earlier at about 14 seconds, we see that more avidly enhancing mass enhanced there. And then a few seconds later, there's kind of some non-mass enhancement a little bit lateral to that. So because of the location of these findings, which would be a difficult MRI biopsy, this patient was recalled for an diagnostic ultrasound. We see an irregular mass there at 3:30, and then just a little bit lateral at 3 o'clock, kind of a more heterogeneous mass there. And interestingly, the first mass was a grade 2 invasive ductal carcinoma, and right next to it, a little grade 2 invasive lobular carcinoma. So these cancers kind of fit the typical things that we see on both MRI and ultrasound. So just a really nice example for that patient. Going back to her screening mammogram, just verifying, and she had just had the screening mammogram within a couple months. Both of the tissue markers from that biopsy, you cannot, even in retrospect, see either of these findings. Our next case is a 48-year-old with a family history of breast malignancy listed there. She also has dense breast tissue. So when you put her history into the Tyrer-Cuzick, which is what we use, she calculates to a 35% lifetime risk. So what do we recommend for her? Again, going back to our high-risk screening criteria, she has the calculated lifetime risk greater than 20% based off her family history. So she is also recommended for an MRI. So this abbreviated MRI was performed in her. This is her MIP. You can see a small mass with some posterior non-mass enhancement in the posterior and inner left breast. There it is on our subtracted axial contrast enhanced image. This went on to MRI guided biopsy and was a grade 3 invasive ductal carcinoma. And this I thought was just highlighting one of the advantages of MRI that we don't often think about is location and the ability to see posterior tissue. Despite multiple attempts to try to get the clip visible on the post-procedure mammogram, it was unable to be seen. So just a nice reminder that MRI, in addition to being more sensitive due to contrast and having no radiation, we also have an extended field of view. So we can see the posterior tissue all the way back to the chest wall. We can also see the bilateral axilla very well, as well as the internal mammary chain. Our next case is a 45-year-old. She has a history of right breast atypia. So otherwise, no family history. She does have dense breast tissue. So what is her recommended screening? So she falls into that intermediate risk based on her personal history of atypia, which the recommendations say they should consider MRI, especially if other risk factors are present. And this patient, she also has dense breast tissue. So this kind of bumps her up into that category of recommending MRI. Another nice example here of our ultrafast imaging. So this is an abbreviated MIP. She has marked background parenchymal enhancement bilaterally. But when you look at our accelerated images, a few seconds after the aortic enhancement, you see pretty widespread non-mass enhancement in her right breast. This happened to be at the site of her atypia. So she went on to MRI biopsy, given how extensive that finding was in comparison to what was biopsied originally. And this is a grade 2 invasive ductal carcinoma with high-grade DCIS. So she went on to mastectomy. Next case is a 35-year-old with a BRCA2 genetic mutation. She had an MRI in 2022, but then was lost to follow-up because of intolerance of MRI. She did, however, continue her mammographic screening, and that was normal. So what can we do for this patient? So, typically with a BRCA patient, we're going to recommend MRI, but she's not doing it because she doesn't like it. So CEM is a great option for her. I didn't look closely enough at Dr. Winblad's slides, so same case here, but I'll give you a little bit extra. So we have our suspicious enhancing mass there in the upper right breast. I thought this was a great case because recalled her from her screening CEM for a diagnostic workup because it was a big enough mass. We thought we should be able to see it on mammogram, but we could not see it on mammogram. Fortunately, we could see it by ultrasound. We do use AI for cancer detection, and I just thought this was a nice example of even AI could not pick it up. So anything below 7 and below on our AI system means that there's no findings that it's going to tell us about. But this went on to biopsy and was a grade 3 triple negative invasive ductal carcinoma. All right, a couple more cases here. This patient is a 43-year-old, and she has a personal history of breast cancer at age 33. So she was undergoing routine screening, and she was also undergoing automated breast ultrasound. So I tend to see this quite a bit. I feel like these patients that had a personal history of a premenopausal breast cancer, and they're getting supplemental screening, which is great, but they aren't doing what's the most appropriate for them. And so her automated breast ultrasound was also negative, but this is where I employ that technique of having a macro. And so I like to put in the reports, and this is an actual report for this patient, that based off of her personal history and the fact that she has dense breast tissue, that she would more appropriately be screened with a contrast enhanced or contrast based technique such as MRI or CEM. And so luckily in this case, her provider saw it. Again, this is a screening exam. So I didn't actually talk to this patient. She was long gone before I read her exam. But someone must have, pointed that out to her, or maybe she reached out to her provider. And she came back for an MRI a few months later. We found a very small grade 2 invasive ductal carcinoma near her lumpectomy site in the left breast. Next case is a 44-year-old transgender female. So what questions are we going to ask for transgender patients? Let's go back to our stuff that we learned in the first lecture. So sex assigned at birth, individual risk factors, hormone use, and surgical history. So in this case, this patient's sex assigned at birth was male. But she has no family history. Oh, I'm sorry. She does have a family history, a mother at age 46 and a grandmother at age 60. And she has been on hormone use for greater than 5 years and no surgical history. So in this case, we are going to recommend that this patient undergoes screening mammography. In this case, it was normal, which is great. And this is just a nice case highlighting how these patients that had a sex assigned male at birth can really have a mammogram that looks much like a cisgender female. So it really is appropriate to be screening these patients. And you can even consider supplemental screening if their tissue is dense. And so after her normal mammogram, we recommended routine screening in 1 year. Case 11 is a 55-year-old male. This patient has a CHEK2 genetic mutation. So what do we recommend for him? So going back to our appropriateness criteria, this is a high-risk patient or higher than average risk. And so mammography is considered usually appropriate. So this patient was undergoing screening. On the left here, we have our prior examination. On the right is our current examination, where you can see kind of a change in their gynecomastia on both sides, but also a spiculated mass there in the upper right breast. This was visualized on ultrasound, underwent ultrasound guided biopsy, and is a grade 1 invasive ductal carcinoma. So then following lumpectomy, what do we do for this patient? So again, we're going to recommend this patient continues with routine mammographic screening. He not only is a mutation carrier, but now has a personal history. And then I believe this is my last case, a 32-year-old lactating female. She has a normal mammogram, but let's review how we screen lactating patients. So remember, we screen them with mammography in pregnancy or lactation, regardless of their pregnancy or lactational status. So the radiation dose is extremely minimal. So there's no change. So this patient, unfortunately, this is not a real case. I'll be honest with you guys. Fortunately, if I guess for our patient population, I have yet to find a screening MRI detected cancer in a lactating patient. Unfortunately, we have tons of cancers that have been found in lactating patients. So this is one of those patients. But I just wanted to show what this can look like on MRI. They have extremely marked background parenchymal enhancement. The cancer you can probably pick up there because it's pretty large sized in the posterior lateral left breast. But when you look at that background parenchymal enhancement, the kinetic data really isn't helping us that much here. You can see on T2 just extensive lactational change. But again, our ultrafast image really nicely highlighting this large, I think 5 centimeter cancer in the posterior left breast there. And this was a grade 3 triple negative invasive ductal carcinoma. So in summary, take time to evaluate your patient's risk status. We are going to see more and more of these higher risk patients walk through our doors. We need to be identifying them as early as possible so that they can get the benefit of screening and the appropriate supplemental screening, and take into account their individual degree of risk, their preference, the cost, the contraindications they may have, and availability. These are things Dr. Winblad discussed that are really important. So not every super high risk patient is going to be able to get an MRI. So know what their options are and be able to recommend them because the cure to breast cancer is early detection. Thank you so much.